my topic is prosthetic valve dysfunction of all kinds and sizes. And as you have heard, we're going through a wonderful time in the history of aortic valve replacement. And I think our life as clinicians evaluating this valve in the future hopefully will get better. But we still have a lot of patients coming around with all kinds of prosthetic valves. So these are the recommendations that are still pretty much valid. Dr. SWVS, I think, is beginning to work on a possible update. And we have lots of valves. You all know this, lots of mechanical types, lots of different tissue valves, and of course now we have also the percutaneous. So no matter how good we get at it, there's still some facts that remain true. One is all valves do produce some degree of stenosis. TAVRs being the best, but it's still a little higher than you would go through a normal valve. Most mechanical valves have built-in trivial regurg, which we have to kind of learn to appreciate. Patients that are getting mechanical valve have a higher incidence of bleeding from anticoagulants over the whatever 20, 30 years of their life, and those receiving biologic valve will have a higher incidence of reoperation because of degeneration. So at the end of the day, when every study have looked at 25, 30 years, at the end they all come about the same with each other, but with two different kinds of major problems. So when we look at this valve, and of course today the first line of looking at this valve is by echocardiography, we like to know how old they are, so when were they implanted, what kind of valve is it, type and size of the patient, because of occasionally there's mismatch, although that's really becoming less of a problem. Symptoms, is this a checkup or is this somebody that is symptomatic? And we'd like to know some simple things like heart rate and blood pressure at the time of the study. When we image this valve by echocardiography, as much as we can, we like to see the actual cause of leaflets, see how they move. Not always easy with mechanical valve. Important, recognize normal structures that are just part of that valve and normal hemodynamics or velocities for that particular valve. And if it's a biologic valve, we're looking for calcification, poor mobility, increased thickening, and importantly, the integrity of the sewing ring, which could be moving a lot as a sign of dehiscence. And at times we need other helps, and we will be covering the other help. Important to realize normal things. This is a mechanical mitral valve, perfectly happy. Now surgeons leave a lot of the subvalvular components in the valve, and therefore we need to know. We need to know what they look like so that we don't start making weird diagnoses that don't exist, like vegetation, clots, and things like that. So this is totally normal subvalvular structures that were left by the surgeon. Built-in leaks, it's important that we know how to recognize them. And of course, every single valve have their set of velocities and gradients that we need to get used to based on the type of valve. So we would like to know valve size, valve type, and flow rates and flow profiles, because these are the things that will determine velocities across aortic and prosthetic mitral valves. For aortic valve, it's very important that we recognize, just like with aortic stenosis, that how we image them may give us the best velocity. Most of the time, the apical window is great, but in this case, you had about a 2.7 velocity that went up to almost 4 when suprasternal notch was used. So occasionally, you have to think of multiple windows if you're suspicious. So, aortic valve, normal versus obstructed. First thing to remember is that the 4V square equation that we use for getting gradients give us different accuracies depending on the kind of valves. And since we use a lot of St. Jude's, it's good to remember that we overcall the gradients with Doppler for a bunch of different factors that we don't have time to get into. Bottom line is, you get higher gradients estimated by the 4V square than what actually there is by catheter. So you learn what those normal values are, and you correct for that. Same thing with valve area. Aortic valve area in a prosthesis is measured the same way that in a native valve. You look at the flow through the valve in the LV outflow divided by the integral of the jet. But since you overdo the velocities, you're going to end up with lower functional valve areas. A 1.2 valve area in a St. Jude would be great. It would not be great in a native aortic valve. And it would not be so great for a bioprosthesis. So you learn what these values are. However, we also know that the continuity equation has two very important components, the ratio of the proximal to distal velocity, and that has been called Doppler velocity index, and that seems to be more stable. So even here at St. Jude's, you can see that most normals are over 0.3, and that is true for practically every type of surgical valve. And as you go down, you have more likelihood of obstruction. So the DVI has become sort of a standard that we use nowadays, and this is taken from the guidelines published in 2009, that there are some very straightforward numbers that tells you a valve, an aortic valve is normal, mechanical valve, or even bioprosthesis. Less than 3, low gradients, triangular early peaking with a short acceleration time, and a DVI over 0.3. Likewise, if you are in a range of 4 meters, very high gradients, low DVI under 0.25, rounded looking contour with prolonged acceleration, that's an obstructed valve. In between, you have this gray zone where you are kind of, maybe yes, maybe not. So this figure that came out on the guidelines also helps you kind of navigate through that. Once you have that gray zone where velocities are higher than 3, then you start with the DVI. And if the DVI is totally normal, then chances are that it's a normal valve if you have a nice triangular shape. Likewise, if you have a very low DVI and a rounded contour, chances are very high that you have an obstructed valve. Now, you may have outliers. You may have a low DVI, but kind of looking okay, triangular-like, and that could be technical. That could be issues with where you place the velocities. And likewise, you may have what looks like a perfectly normal DVI, but very rounded contour. That, again, should raise suspicion for other possibilities of aortic narrowing, underestimated gradients, improper LVOT velocity. So there are outliers that you have to keep your mind thinking, because then that's when you may want to go to another modality for testing. Now, the new valves are changing the landscape, right? Because now we have these fantastic valves, TAVRs, and some of the new bioprostheses that are giving us extremely low gradients and low velocities. So it's very common to have 2 meters or less as a peak velocity in a TAVR, or even in a trifecta or some of the newer valves. Prosthetic mitral valve, it's the same concept. It's the same concept. You have a mechanical valve or a bioprosthesis, it's going to have some higher velocities. So you need to know the velocity, mean gradients. Pressure half time can be of some help. 90% of the time, it might be very helpful. And you like to estimate a orifice area, again, using the continuity equation, which is the same story. You measure the flow through the LV outflow, and you divide it by the integral of the mitral valve, and that gives you a functional valve area, as long as there is no mitral regurg. Because if you have significant MR, this TVI is going to go up because of higher flow, and you get what looks like a low gradient. So this works well in the absence of prosthetic mitral regurg. Same as the aortic valve, you have the components of the ratio of velocities. So the TVI in the mitral divided by the LVOT TVI is an index that, just like in the aortic, it can be used for function. Normal, less than 2.2. The higher it gets, the more suspicious you are of obstruction, but also of regurgitation, as I'll show you later. So this would be a typical obstructed valve, high velocities, prolonged pressure half time, high gradients, mean gradient 13, and a DVI, Doppler velocity index, that would be very increased. And this is, again, from the guidelines, normal typical values that if you have them are almost 99.9% for obstructed valve, very high velocity, high gradient, prolonged pressure half time, and a velocity index much higher than 2.5. This is your gray zone, where sometimes the same way as with the aortic, you scratch your head. And the recommendation is, if you are either gray zone or definitely obstructed, it's good to proceed then with the transesophageal, because that may help us clarify A, function, B, etiology. So now that we have identified or suspected an obstructed prosthesis, What are the mechanisms? Well, if it's a mechanical valve, 99.9 is either thrombus or pannus. If it's a biologic valve, most of the time it's a chronic, slow process of degeneration, and actually transthoracic quite often picks it up, but with the TE you can actually see it even better. And occasionally you have the zebras, so masses, tumors, and occasionally a bad valve. Those are very early diagnoses because it's a bad valve coming out of the manufacturer. So some examples of clots in a mitral valve. This is before and after thrombolysis with good mobility of the disc. Here you see it in real time, a nice a bunch of little clots in the valve, high gradients. A clot in the aortic valve. Notice the soft density of that. Another clot in the mitral. A little area of clotting here. And here you have a pannus. See how much dense this looks? This is a much denser structure than the soft structure of the clot, and this is how it looked taken off the patient. And years ago, a study was done here where we look at clinical parameters and TEE parameters, and the bottom line was that if you have inadequate anticoagulation and a soft mass in the valve, chances were very high that you had a thrombus. It was not perfect, but it was helpful. Likewise, if you had excellent anticoagulation and a very high dense looking mass, were more chances for a pannus. But it's not that easy. And this is where other modalities can be very helpful. So fluoroscopy can help you a lot by looking at the mobility of those discs. And this is from a nice picture in a journal, but this is reality. And you can see how those discs are moving and how this one, for example, is not opening well. This requires some experience because you have to learn how to manipulate the X-ray tube to have the right angles to be able to put the disc right in a parallel fashion that you can see them. And anybody can do that. You can take a patient to fluoroscopy and do it very easily. Now, CT is like a no-brainer because you see so well that then you see very clearly how this particular disc is stuck. You can see it also very nicely in this view. And sometimes you can see clots and pannuses. So here with CT, there have been publications showing the normal angles that you can have in a normal St. Jude's versus an obstructed St. Jude's. This is an example where a clot is seen in the valve. Here you have the TE showed nothing of much help, and yet you could see that area of black density that that was a pannus when the valve was extracted. So, and this is a clot in a TAVR valve. So even with tissue valve, we can see little clots forming. In fact, this is a very important area right now of evaluation, and this is why many of these bioprostheses, including TAVR now, there's a tendency to maybe anticoagulate for 3 months because serial CT studies are showing little clots in this valve, and we still don't know exactly what that may end up being from the point of view of clinical outcome for the patient. The degenerated valve, they're easy. You see thickening, you see degeneration, you see calcification, so those are not difficult to diagnose. Prosthetic aortic valve regurgitation, most of the time transthoracic can do a very good job because the jet is coming right at you, there is no major attenuation factors, and you basically can assess it quite often like any other AI, using color, using CW, using retrograde flow in the descending aorta, and therefore, now TEE is extremely helpful for the mechanism because a lot of the regurgitant prostheses are perivalvular leaks, and you can see them very nicely with TEE. So TEE for a prosthetic aortic valve leak is very helpful, and also for a prosthetic mitral valve leak. This is available in your handouts. You're going to be getting all of this in a PDF handout, so you can look at them. These are criteria established from the ASC to try to go through the process of deciding is mild, moderate, severe. With echocardiography, one can actually do regurgitant volumes because you can do LV outflow flow and pulmonic flow and compare them. If you have experience, you can do that. CMR can be extremely, extremely helpful. The bad guy here is the TAVRs. And it's great to hear that with new technology, the paravalvular leaks are becoming less because they have been a challenge to assess. They don't never look as bad as a paravalvular leak in a surgical valve. So you have this that looks like mild, this looks like severe, But in real time, look at that. Is this mild or severe? Well, if you go to the short axis, you can see that the leak is covering more than half of the circumference of the valve. You have a lot of CW tracings with density on it. And when you manipulate the probe a little bit more, you see a lot of flow going around the circumference. And lo and behold, there is some retrograde diastolic flow in the aorta. So this was not a little leak. Yet, the first impression when you see it is not that impressive compared to the surgical valve. So TAVRs have been more difficult, and in fact, it's a combination of findings. The vena contracta width is still evolving. I think what people are using the most these days is the extent in the circumference of the ring of the leak. 50% or more is bad news. Between 30 and 50, people scratch their head, and less than that is considered to be mild. When in doubt, CMR again can be very helpful as long in patients that do not have pacemakers. Prosthetic mitral valve, transthoracic, very, very problematic because that's where you have a lot of attenuation from the ring. And again, that same Doppler velocity index that can pick up a stenosis can also pick up regurgitation because of high velocity through the valve, so the integral becomes high. So the same numbers give you a suspicion for either, and that's why earlier I said TEE is extremely helpful because TEE allows you to very quickly see a paravalvular mitral valve leak. And again, there are criteria that have been established to look at that. This is a physiologic valve, just for comparison. This is a leak, very bad leak. And there are several things you can use to try to get into mild, moderate, severe, but recognizing that even a mild paravalvular leak in the mitral valve can give you severe hemolysis. So hemolysis can be a game changer because of the frictions and the loss of blood cells, even with a mild leak. Nice case that has a patient that had a prosthetic mitral valve, some aortic stenosis, very tough echo to do. This jet looked rounded in the aortic valve, but the velocities were not very high. Here's the mechanical valve. We couldn't see much at all here. So as patient was symptomatic, CMR was done, and picked up first a perivalvular leak, which was shown very nicely to be present and to be quite significant, regurgitant fraction of 30%. And then the aortic valve was assessed, and in fact, the valve area was also 0.9 and a peak velocity of 4.25 using phase contrast. So CMR frequently can help us rescue some of these evaluation, particularly for aortic stenosis and for paravalvular leaks quantification. So I leave you with these thoughts. You know, we need to know information that is clinically important, type of valve, baseline, but in cases with high velocities and high gradients, suspect stenosis or regurgitation, and the velocity indices of either valve are very helpful. Try to compare with previous studies, and multiple other modalities can be very helpful. TEE for mitral valve clots, degeneration, MR, AR, CMR for quantification of either MR or AR, fluoroscopy, CTA for mechanical valve, looking for the typical obstruction, trying to identify panus and clots. I have a few more slides in the handouts that are for tricuspid and pulmonic, that I left them there for you to review, but I was not going to cover them. Thank you very much.